Oh, okay, good. Yeah.
Good afternoon. Welcome to Grand Rounds today. As I generally do, I will remind you to fill out the attendance record at the back of the auditorium, and also to please fill out the program evaluations and turn those back in. And if you could give us any ideas in regards to future topics or future speakers, the CME committee is always appreciative of those thoughts. Also, we will not have a scheduled Grand Rounds next week or the week thereafter, and so we'll be reconvening on July 12th with our next Grand Rounds presentation. Today, I have the pleasure of introducing Dr. Michael Kitchell, who is well known to the Grand Rounds audience. Dr. Kitchell wears several hats at the clinic and at MGMC, but what is particularly germane to today's presentation is the fact that he's board certified in neurology and also certified by the American Society of Neurorehabilitation, and he is the medical director for the Mary Greeley Medical Center Rehabilitation Unit, and he is here today to update us on stroke and rehabilitation. And please join me in welcoming Dr. Kitchell.
So I don't know if many of you know this, but I've been the director of the rehab program here since 1986. And so we've had a rehab program here for 30 years, but I sometimes think it's one of Mary Greeley's best secrets that we don't often hear about in the public. But again, we have a rehab program that has now 12 beds, and we're going to be building it up to 17 beds in the next year or so. So I'm going to refresh everybody's recollection about stroke, and then I'll be talking a little bit more about rehabilitation too. So I'm happy to take questions too as we go along, as long as they're not too lengthy, but we will have time, I'm sure, at the end to go over some questions either about strokes or about rehab. So, as you know, strokes are due to a blood vessel problem, and it's a loss of function that's usually sudden, and it's also known as a brain attack. I'll talk a little bit more about the differential diagnosis later, but in younger people, the differential diagnosis can involve migraine headaches. I occasionally see people who are referred for strokes who actually have had a seizure and they have some postictal weakness or postictal speech difficulty. I occasionally see people who have an encephalitis. For example, herpes simplex encephalitis can have a pretty sudden onset and can be a focal type of problem, like with the speech or with the alertness and communication ability. One other differential that you don't want to miss is a subdural hematoma, and sometimes elderly people who have had a history of a fall, their subdural hematoma may be silent for a while and then suddenly they'll become symptomatic. Now, we obviously do a CAT scan before we do any other evaluation of a stroke patient, but you don't want to miss something like a subdural. And then occasionally we see some people who present explosively with a tumor. Sometimes people who have a brain tumor develop sudden swelling, or they may bleed into the tumor, and so it presents with a stroke-like onset. So people always ask me, well, how do you know when it's a TIA, a transient ischemic attack, or whether it's a reversible ischemic neurologic deficit, or it's a stroke? In the olden days, before magnetic resonance scans, a lot of people who had what they thought were TIAs or RINEs actually are now found to have a small stroke. It's not unusual for us to have a patient who has some symptoms for a few hours, and then by the time they get better, we do the MRI scan, but yet the MRI scan actually shows that there has been a stroke in that territory. So a stroke is defined as a fixed deficit, that is a loss of some neurologic function. And as you know, they can be due to a lack of blood flow that is ischemic, or they can be due to some sort of hemorrhage. Now, ischemic strokes are about 85 to 90% of all strokes. Here at Mary Greeley, we keep track of the statistics, and actually over 90% of the strokes that we see here are ischemic. In particular, we have fewer aneurysmal bleeds than the national average. I think that's because most of our population has pretty good control of their blood pressure, and so we tend to see a little bit fewer hemorrhagic strokes, but more ischemic strokes. The other interesting statistic here at Mary Greeley is we have more older people than the national average who have strokes, but we have fewer younger people who have strokes. And I like to explain that on a simple fact that, again, we have people here who are taking care of their diabetes, they're taking care of their blood pressure, they're taking care of their cholesterol. So instead of having a stroke in their 50s or 60s, people in our area are having strokes in their 70s, 80s, and 90s. So again, our statistics here are a little bit different from the national average. And as you know, strokes can be either large or small, and it depends upon which blood vessel or blood vessels are involved. And just like you know, cholesterol deposits can affect the blood flow through the heart, they can affect the blood flow in the brain. Those cholesterol deposits don't just narrow the blood vessel. As you know, they can break off, and then sometimes platelets can adhere to the area where there is an ulcerative plaque, and that can cause more platelet emboli to go downstream and cause a stroke. So those clots can form either due to the cholesterol narrowing and a reduction in blood flow, or they can be caused by that ulcerative plaque that then sends those platelet emboli downstream. One cause that has been getting more attention over the last 10 or 20 years is atrial fibrillation. In a younger population, about 50% of the people we see with strokes, that's ischemic strokes, about half the people that we see, we don't find a cause for their stroke. In other words, they don't have a cholesterol problem, they didn't have a plaque, they didn't have a carotid dissection that caused a sudden narrowing of the blood vessel. We don't know the cause. And what they've done in the last few years is they've actually done extended monitoring, sometimes with a loop recorder. The cardiologist will put in a recording device so that we can not only do a 3-day test to see whether there's atrial fibrillation, that is intermittent atrial fibrillation. And so sometimes they're monitoring patients for a month or even as long as 3 months now to see whether they have intermittent atrial fibrillation. Because if they have intermittent atrial fibrillation, that could be the cause of a clot that develops in the atrium, and then it suddenly breaks loose and causes a stroke. So again, the atrial fibrillation can be intermittent. It can be hard to diagnose. Now, this is a pretty easy statistic to remember. Most people think when they're talking about a stroke, they think, oh, the carotid artery. Well, as you can see here, only about 25% of strokes are actually involving predominantly the carotid artery. Small vessel strokes are very common in diabetic patients, so are large vessel strokes too, but we will often see people with a long history of diabetes who have a number of small strokes, some of which might even be asymptomatic. So about 25% of strokes involve the vertebrobasilar system, and those again have some different signs and symptoms than the people with carotid artery disease. One thing that I try to get physicians who are working up a patient to understand that if they've had a cerebellar stroke or they have a brainstem stroke, you don't need to do a carotid Doppler. You might want to do a CT angiogram, but you really don't need to do a carotid test if the patient's had a stroke in the vertebrobasilar circulation. The other thing that I find is I have physicians who work up a patient with a blackout event, with a syncopal event. They suddenly pass out, and we don't know whether it's a cardiac arrhythmia. We don't know whether it's a seizure. We get asked to see these people all the time. The cardiologists get asked to see these people all the time that have some sort of unexplained passing out spell. We don't do carotid Dopplers on people with syncopal events because there's no patient who has had a carotid stroke or carotid TIA who loses consciousness. So we don't need to do unnecessary carotid Doppler testing on people who've had a simple passing out spell. Vertebrobasilar artery TIAs do occasionally cause a loss of consciousness. Sometimes people with a vertebrobasilar TIA can have what we call a drop attack. That means they suddenly drop, they lose their postural tone, so they can suddenly fall. And they may not actually lose consciousness. They'll just simply tell you that they were walking along and suddenly, boom, they fell to the ground. And they actually tell you they didn't lose consciousness with that. That vertebrobasilar artery TIA is, like I say, called a drop, D-R-O-P, drop attack. And so that can occur because there's low flow, or what we call vertebrobasilar insufficiency, so that people have a temporary loss of that postural tone that's in the brain stem. Now, getting back, though, to the causes of ischemic strokes, atrial fibrillation and atrial flutter is involved in about 25% of strokes. And if you look at the younger population, like I say, where we don't see cholesterol deposits or some obvious cause, that's where a lot of these patients can be found to have intermittent atrial fibrillation. Now, one of the rare causes of stroke that I've seen over the years that is a real dangerous situation for emergency department physicians or sometimes physicians in their offices is an aortic dissection. As you know, the aorta carries blood from the heart to the carotid arteries. It also goes to the kidneys. It also goes to the legs. Sometimes people develop an aortic dissection where there's a tear in the wall of the aorta. I'm not talking about an aortic aneurysm that blows or ruptures. I'm talking about a dissection. That means that the blood goes into the aortic blood vessel wall, and then that compromises the blood flow to the branches off the aorta. And one of the branches that's often involved with an aortic dissection is the blood vessels to the spinal cord. And so you can have a carotid occlusion or carotid decrease with an aortic dissection. I actually saw one of them here. We rushed him to Des Moines. Unfortunately, he had his aortic dissection corrected, but he was having a stroke-like onset. And imagine if we gave that patient TPA. That wouldn't do him much good. So fortunately, we were able to pick that up. So the other thing that sometimes can be caused by aortic cholesterol deposits is sometimes they will break off, and just from the aorta itself, there are some cholesterol emboli that can cause some strokes. Those are obviously rare, though, compared to the 4 major causes. I think most of you know that symptoms of an ischemic stroke can involve usually unilateral symptoms. It's very rare to have bilateral symptoms. Obviously, if you have a basilar artery problem, it can be bilateral, but that's a very rare situation. So some sensor loss on one side. It's not usually my hand goes asleep when I wake up in the morning. That's carpal tunnel syndrome. But if you have somebody who says my face and my arm went numb, or my arm and my leg went numb, that's where you have to be suspicious about it. And obviously weakness can be arm, leg, hemiparesis. So all types of variable motor loss. And then, of course, you can have some cerebellar strokes. We have a patient right now who's had multiple cerebellar strokes, and she's got some dysarthric speech. She's got some dysmetria in her arm and in her leg because she's had some cerebellar strokes and cerebellar deficits. Speech difficulty is often a symptom of stroke as well. And then, as I said, loss of balance or some cerebellar difficulties. Remember, though, that sometimes a cortical stroke can involve the leg, and people will have balance difficulty because of some involvement of the anterior cerebral artery, and they might have some gait difficulties because of that. So it's not just a cerebellar cause for someone to have a gait problem. So as I was talking about earlier, migraine headaches in a younger population is something we have to rule out. Remember, a migraine aura is often a visual disturbance with some positive symptoms. In other words, some flashing lights, some shimmering lights, some blobs or fortification spectra that kind of move from one part of your visual field to the other. And some people with a migraine can actually lose vision on one side. They can have a homonymous visual field loss. Migraine auras generally last from about 10 minutes to 45 minutes. They rarely last more than 45 minutes. But obviously, if a patient says for 30 minutes I had trouble with seeing out of one side of my vision, it could be a migraine or it could be a TIA, and we do have to work those patients up. Rarely patients, especially younger patients, but rarely patients can have what we call vertebrobasilar symptoms with their migraine, not just the visual disturbance, but they can actually have some dizziness, they can have some numbness. We do have some patients with migraines who actually have an aphasia with their migraine attacks. So again, that's the differential diagnosis. I had a patient one time that the physician phoned over as needing TPA because she had a hemiparesis, but they failed to note that she had a seizure. And when I saw the patient and was already telling the nurses, get the TPA ready, she obviously was having a focal seizure with her eyes twitching toward the side, and that was a side that was weak. So TPA does not help anybody who's had a postictal paresis from seizure. So obviously with a generalized seizure, you're not going to have focal signs or symptoms. And when we are thinking about stroke as a differential diagnosis, we're obviously thinking about something that's got some focal signs. There are occasional patients with multiple sclerosis who can present pretty suddenly, pretty dramatically. Usually the CAT scan or the MRI scan, though, can help to make that diagnosis pretty easily. And then, as I mentioned earlier, subdural hematomas are not uncommon in older people, and they can present with a sudden neurologic deficit. They might have a hemiparesis, they might have some speech difficulty, and of course you do the CAT scan before you do any treatment of a stroke, so you're going to be able to pick up the subdural hematomas with that. And then, as I mentioned earlier, tumors, there are a number of people in my recent memory that the radiologist diagnosed a stroke, or we thought the patient had a stroke, and then we find out later that this was actually a hemorrhage into a tumor. And so that is not unusual for tumors to present that way. Now, obviously, some people who have spinal cord pathology can present as having a stroke-like onset. We actually had a lady on the rehab program about 4 to 6 weeks ago who had an infarct involving her spinal cord. She actually had bilateral signs and symptoms, and fortunately she did have an improvement over a period of time, but that was an ischemic event involving her spinal cord. Now, a peripheral neuropathy is what is sometimes a problem too. People will wake up with a wrist drop, okay? So they'll come into the emergency department and say, hey, my wrist is weak, I can't grip. I've lost my grip and I can't raise my wrist. And then they have a little bit of weakness of their elbow flexion too, because their brachioradialis muscle is involved. And then they might have a little triceps weakness too, because the radial nerve supplies the triceps, the brachioradialis, the wrist extensors. And if you have a wrist drop due to a radial nerve palsy, you won't be able to effectively grip. So sometimes a peripheral neuropathy comes into the emergency department and the physician thinks, ooh, they've had a stroke involving their arm, when they actually just slept on their radial nerve, either in the axilla or on the side of the humerus. So peripheral neuropathies can be mistaken as strokes. As I mentioned too, if someone wakes up with their hand numb and they're shaking it to get it back to normal, that's carpal tunnel syndrome until proven otherwise. But people will swear that their whole arm is numb when they have carpal tunnel syndrome. So just be aware that you can't always rely upon the history. So a median neuropathy is the carpal tunnel syndrome. So again, it's just in the differential diagnosis. And then, as I said, I've had a number of patients over the years who presented with a stroke-like onset, and they actually had herpes simplex encephalitis. And as you know, herpes simplex I think you know, herpes simplex encephalitis is actually treatable. And so we need to make sure that we have the right diagnosis in those patients. And then the bane of a neurologic consultant's existence, we get a lot of midnight and 2 a.m. phone calls from people who have psychogenic symptoms. They might have a weakness on one side, or they may have unsteadiness. And so the emergency department physician calls and says, I think they're having a stroke, but it's a little bit inconsistent. And so, unfortunately, there are a number of people who are, for either a conversion reaction or for malingering, they are having some deficits on one side. I had a lady who was up on the floor who was simulating hemiparesis. She was walking around like this, and she was closing her eye as if she had some weakness of the right side of her face. But I pointed out to the nurses that no, she was actually closing her eye and drawing up her face, which is the opposite of weakness of the face. So again, it sometimes is difficult to be sure, but there is unfortunately a number of people out there who, for some reason or another, do present with some psychogenic symptoms. So it's a pseudo stroke. And unfortunately, some of those people actually get TPA for their pseudo stroke. Okay, I think most of you know the risk factors for stroke, but obviously as we all get older, we have a higher risk for stroke. As I mentioned, though, our population here in our area, we have people who have strokes at a later age because they are healthier at a younger age. And so those cholesterol deposits or those problems of aging occur at a later age rather than a younger age in some areas of our country. And then obviously hypertension is a real risk factor. The reason the stroke incidence has gone down over the years has been primarily due to high blood pressure treatments and cholesterol treatments. And so we do have a healthier population for those two reasons. Whenever I see a patient who's a cigarette smoker, I tell them that I'm going to give them 3 prescriptions. First one is stop smoking. Second one is stop smoking. Third one is stop smoking. Because those are the 3 most important reasons or most important treatments to keep people from having strokes. And you know that's the same with heart attacks. So of all the things that you can do to reduce your risk of stroke, you know, I'm sure hypertension and cholesterol treatments are important, but cigarette smoking is the most important, easily remedied risk factor for stroke. And then, as you know, LDL cholesterol levels are associated with higher risk of stroke and heart disease. Obviously, if you have a family history of early heart attacks or early strokes, that's another risk factor for strokes. And of course, diabetics have a higher risk as the years go by. I think I've told the audience here, our treatment at McFarland Clinic of our diabetic patients is among the best in the nation. We have, from statistics from Medicare, we know that our diabetic patients here have 1/2 the national average, 1/2 the national average of hospital stays per year. So we must be doing a pretty good job of treating those diabetic patients who don't have strokes, who don't have heart attacks, who don't have diabetic amputations, who don't have diabetic problems. So again, treatment of diabetes, if it's successful, you will, again, if you're going to have a stroke, you'll probably have it 40 years after you've had diabetes rather than 20 years if you didn't take care of your diabetes. The other thing is a lack of exercise. I'm probably pretty preachy about this, but there is no question that for many neurologic diseases, strokes, dementia, Parkinson's disease, one of the best treatments for people is exercise. So if you want to prevent dementia, if you want to prevent heart attacks, if you want to prevent strokes, exercise. And obviously you know that it's aerobic exercise that is more important. Then being overweight or obese is a real risk factor. I was at the AMA meeting in Chicago recently, and there was a program on obesity and overweight patients. And as you know, we have an epidemic of obesity in this country. The lifespan of someone who has a BMI of 30 to 35 is going to be 10 years shorter than people who have a normal BMI. And every 5 points of the BMI above 35, you're taking 2 years off your life. So the average person who's a BMI of 35 or above, 35 or above, is going to have a lifespan of age 60. So being overweight is not good. Being obese is really dangerous. There are 13 types of cancers that are also increased in people who are overweight and obese. So again, it's a risk factor for stroke, but there are lots of other reasons to avoid obesity. Okay, how do we work up a TIA or a stroke? Well, obviously, if somebody comes to the emergency department like they're supposed to, if they have a sudden onset of a neurologic deficit, we will get a CAT scan. We're trying to set things up so that the neurologist doesn't even get asked to see the patient until we actually get that patient rushed into the CAT scan and we get the report. Now, once the smoke clears, the rest of the workup could include a Doppler of the carotid arteries, because that obviously is a major cause, an echocardiogram. A magnetic resonance scan is not part of the acute or emergency workup for a stroke, but we usually do one. And then a CT angiogram is also very helpful, particularly if you want to look at the vertebrobasilar circulation. That's how you need to do that. The radiologists prefer a CT angiogram over a magnetic resonance angiogram, but either one is sufficient too. And then, of course, in younger people, we will do some clotting tests to see whether they have an abnormal tendency to form clots. So if you recall a few years ago, TPA was helpful in the first 3 hours. Well, as more studies have been done, they've actually found that there's still some benefit even after 3 hours in people who have neurologic deficits. So we do give TPA up to 4.5 hours. Now, if somebody doesn't get there quickly enough and they have a major deficit, that is, if they have a large blood vessel clot, for example, in the middle cerebral artery or the carotid artery is occluded, we actually are now shipping those patients to a stroke center, usually the University of Iowa, for an intervention. Because interventions of taking a clot out of the carotid or the middle cerebral artery actually has been shown to be effective. They have better outcomes, even up to 6 hours. And that 6 hours may actually be extended for some patients with vertebrobasilar disease. So again, they can go in with a catheter and actually pull out that clot. And the patients do have a better outcome with that intervention. So again, getting back though, if we treat the patients here, we don't treat the blood pressure unless it's basically over about 185, over 110. They've done studies, and people that have blood pressure that's dropped into the normal range actually did a little worse than people who were kind of in that medium range. If it's 200 and some over 120, we do treat the blood pressure then. Now, as you know, aspirin is a very important treatment. In fact, that's the first thing we do. In fact, I had a patient with a TIA who took aspirin as soon as he had his TIA and before he got to the emergency department. But if they're not on aspirin and their CT scan doesn't show a bleed, we give them aspirin quickly. And obviously, if they have atrial fibrillation, we use anticoagulants. If it's not atrial fibrillation, we generally use Plavix. Sometimes we do use a drug called Agrinox, but that's not as often anymore. And then, of course, as part of the treatment for ischemic strokes, we have rehabilitation. And so we offer people who need an extended period of time for more therapy, an inpatient program here. And that's going to be 3 hours of therapy with physical therapy, speech therapy, and occupational therapy. So as I was saying earlier, if we see a patient who's got hemispheric signs, a visual field loss, an aphasia, and a right hemiparesis, they are going to be shipped for an intervention. Even just doing a CAT scan and a neurologic exam, we are getting them in a helicopter and getting them to get their interventions done. And so that's a 6-hour time period. And of course, if they have a right hemisphere stroke, they're going to have a left-sided neglect. That means a left hemisensory deficit as well as a left hemiparesis and a visual field loss. So we can tell pretty easily whether this is a large vessel stroke or a small vessel stroke. If people just have a little dysarthria, but they have no hemiparesis, they have no visual field loss, that's not going to likely be a large vessel stroke. We wouldn't ship that person off. So again, we originally thought, well, maybe we should do the CT angiogram to confirm that they have a clot in their middle cerebral artery or their carotid artery. Sometimes on a CAT scan, you can actually see, the radiologists can sometimes pick this up, they can actually see the clot in the middle cerebral artery. And so that is definitely an indication to get that patient off to a center where they can take that clot out. So I had a patient over the weekend too that unfortunately had this fourth complication. She had an anterior cerebral artery and a middle cerebral artery stroke, and she was still able to speak because it was in the right hemisphere, but she got progressively sleepier, and then on Sunday morning she developed a blown pupil on the side, and that was an indication that there was swelling that was pushing down and causing a little bit of brain herniation. So we again had to ship her off to Iowa City to have a craniotomy to reduce that pressure in the brain. So again, those large ischemic strokes can be really pretty dangerous. So to work a patient up for a carotid stenosis, again, our goal is if the patient with a stroke has a carotid artery narrowing that is 50% or more, we will offer that patient an endarterectomy. The studies originally showed that the carotid stenting and angioplasty versus an endarterectomy, where the surgeon opened the artery and took the clot out, or took the cholesterol out, they were about the same. But as time has gone by, they actually believe that a carotid endarterectomy is superior. But if that patient has a lot of other medical problems and would be at high risk of having a general anesthetic and surgery, then we do offer the stenting rather than the carotid endarterectomy for surgery. So again, it's a 50% stenosis. If the patient has been found, like I said, to have a carotid bruit, but they didn't have any TIA, they didn't have any strokes, we don't send people off for a carotid endarterectomy or for stenting. There might be a few cases in a younger patient where an 80 to 90% stenosis might be offered a carotid endarterectomy, but basically if the patient is asymptomatic, even with an 80% narrowing of the carotid, we don't intervene. There's about a 3% risk of a carotid endarterectomy and a 3% risk of the carotid stenting. But the risk for that patient who's asymptomatic with a 70 or 60% stenosis, the patient's not going to be better off by having anything done to their carotid. So as I said, for high-risk patients, carotid angioplasty and stenting is a little better than the carotid endarterectomy. So hemorrhagic strokes, we're switching from the ischemic now to the hemorrhagic strokes, okay? So you'll find that the type of presentation is often telling you what the actual cause is. If we have an older patient who has what we call a lobar hemorrhage, not in the basal ganglia, not in the deeper areas of the brain, but up near the cortex, that is often due to what's called amyloid angiopathy, and that is a problem in some people with Alzheimer's disease. They not only have amyloid plaques in the brain, they can develop amyloid deposits in their arteries in the cortex, and I've seen people with multiple lobar hemorrhages due to that amyloid angiopathy. But the typical hemorrhagic strokes that are due to hypertension are usually in the basal ganglia, in the thalamus, in the internal capsular region, and those are pretty typical for people who have hypertension and then their blood pressure spikes. Again, we don't have as many of those type of strokes here as they do nationally. Occasionally, a hemorrhage in the brain, as I was saying earlier, can be due to a tumor that suddenly bleeds into it. Sometimes glioblastoma multiforme can present that way, and those people just do very poorly. Occasionally, we'll see an arteriovenous malformation. And in fact, when we do a workup of a patient with a hemorrhagic stroke, if it's a lobar hemorrhage, or if it's a little bit suspicious, we might repeat an MRI scan with contrast later, trying to make sure that they didn't have a small arteriovenous malformation that caused the bleed. As you know, aneurysms can cause subarachnoid hemorrhages. Those are fairly easy to pick up. Not that some of them are not missed, but if you do a CAT scan, usually you can see that subarachnoid blood. Now, if a person has a hemorrhage in the brain and it goes into the ventricles, that's always a poor prognosis. And I had a patient recently in the last month who had a very large hemorrhage in the lobar hemorrhage that was going into the ventricle. And the family obviously wanted to know what they should do. And in the end, we know, though, that people with a large hemorrhage like that, even if you have the neurosurgeon drain the blood, their outcome is the same. And so neurosurgeons are rarely intervening with large hemorrhagic strokes anymore. The type of stroke they might intervene with is a cerebellar hemorrhage, because that cerebellar hemorrhage can sometimes press on the ventricular system and cause hydrocephalus, and people go downhill rapidly. But as I said here, surgery for drainage of the hemorrhage, it only reduces mortality. It doesn't change their outcome. And so if it's a huge hemorrhage, it's a bad outcome. Okay, so treating the hemorrhagic stroke, find the cause. If the patient is on Coumadin or another anticoagulant, you quickly stop it, you try to reverse it. If it's an aneurysm, neurosurgeons are no longer doing a craniotomy and clipping the aneurysm. The neurointerventionalists are putting a coil in, and that actually clots off the aneurysm so that people don't have to have a craniotomy. And then even in hemorrhagic strokes, if we admit them here, we don't try to get too aggressive in treating their blood pressure. Again, just put it in the moderate range. So prognosis for hemorrhagic strokes, there's a 5% recurrence after lobar hemorrhages per year. There's a 3% recurrence if it's basic ganglia or thalamic. And if they were on Coumadin or another anticoagulant, actually it's been shown now in a good study that despite the hemorrhage, and again there's a risk of putting that person back on Coumadin, it's still better to resume the Coumadin because their risk of having an atrial fibrillation caused stroke ischemic stroke is higher than their chances of having a hemorrhage. So the recommendation now is to resume the anticoagulant after about 3 weeks. Okay, most of you know how to prevent ischemic strokes. As I talked about, aspirin and Plavix, anticoagulants for atrial fibrillation, low cholesterol diet, statins, no smoking, exercise, and then of course diabetic control. So now I'm going to talk about rehab, and I hope I have enough time to get through all I want to say. But if you compare our intensive program, which is 3 hours of therapy, versus a skilled care setting or a nursing home setting, the results, the outcomes for patients are definitely superior. So we do urge everyone who has had a stroke, who needs some rehab, get to an inpatient rehabilitation facility where they are specialized with those type of treatments. And I'm going to just briefly talk about functional independence measures. Those are measures of the function of the patient. And so everybody who is admitted to the rehab program has a functional independence measurement score. Our therapists and our nurses know how to rate these people. And so obviously the people with the lower scores are the ones who need more help, and the people with the higher scores are doing well. They're needing maybe a cane to walk. That's a functional independence measure of 6 out of 7 if they can walk with an assistive device, for example. So what we're doing on the rehab program is measuring our improvement, and that's an improvement in the FIM score, the Functional Independence Measurement Score. Our average stay on rehab for a serious stroke, for a severe stroke, is about 21 to 24 days. That means that some patients who are really severely affected are not going to be going home after 3.5 weeks. They will probably need further therapy and a longer-term rehab for those really major devastating strokes. But we have about a 75 to 80% success rate of patients going home from our rehab program here. So that's a pretty good percentage. Now, most of you who have been here for a while know that we are an approved stroke center. It's called a primary stroke center. The University of Iowa is the comprehensive stroke center. So there are about 9 other programs around the state of Iowa that are part of that stroke center comprehensive program. So again, we do work closely with the University of Iowa for those patients, particularly those who need those interventions. And then we also have some measurements for stroke and for rehab, and these are just some of them that I can go over if you'd like. But we are measured with how quickly we can give TPA. We want to have a sprint. As soon as the patient gets to the emergency department, we want to get them to get the TPA within 45 minutes. We're not successful unless we can do it in 40 to 45 minutes. So we want to be able to assess that patient, get that CAT scan, get the patient and the family a discussion of the benefits of TPA, and get that needle in and get the TPA going within 45 minutes. So that's the door to needle time that we're looking at. And that's what every other stroke center around the country wants to do, because time is brain. And just like a heart attack, the quicker you can get the problem corrected, the better off the patient will be. So I'll take some questions now, either about these measures or anything in general. Yeah. You're saying, okay, obviously when people are at risk of having a stroke, whether it's a family history or any of these other risk factors, yeah, we hope that the people who are the first responding will recognize that this is a stroke situation, and then we want to red flag those people so we can zip them into the CAT scan and get their assessment done as quickly as possible. So again, for somebody who's got some risk factors, work on reducing those risk factors so you won't ever have to worry about going to the emergency department for a stroke. Somebody else up there?
What frequency, or how often do you have to send people to the center at Iowa City for a clot removal per year? What's the number?
Yeah, I would say probably 5 or 6 per year. Would you say?
I would agree with that.
Yeah.
The other point I want to make about the comprehensive about it is they still do the clot retrieval even if we give TPA. That's always the question. Go ahead, give the TPA here, and if it's not effective, then we still can have the opportunity to send to Iowa City.
Yeah. So as she said, even if we give TPA, and we will give TPA for people who have that clot sign in their middle cerebral artery, the thing that the University of Iowa didn't want us to do was to put more dye into the patient for a CT angiogram, because they would be then limited by how much more dye or contrast material they can give in Iowa City. So again, yeah, the TPA, we still want to give the TPA because that might help to clear things up even before they get to Iowa City. Right. Yeah. So we definitely want to give the TPA even if we do send them off. Jack.
Yeah, Mike, I have a patient I'm treating for depression. He's in his 40s, no history of migraines, was umpiring a Little League ball game, collapsed, taken to the hospital. They said at first he'd had a stroke, later heat exhaustion, but 10 days after he still is blind in one eye. Does that suggest a stroke?
Okay, good question. When the patient is blind in one eye, that would suggest that he probably had some sort of embolic event in the carotid, and that's where the clot can sometimes lodge in the ophthalmic artery. So sometimes when people have amaurosis fugax, they have a temporary loss of vision in one eye. But if that person is blind in one eye, that would suggest that there probably was a cholesterol or some sort of clot that went up the carotid, caused the stroke, and then he's got the visual field loss. Most of the people who have amaurosis fugax, it's not permanent though. People who have a permanent loss of vision in one eye, that's an ophthalmic artery problem, those people have to be checked out for giant cell arteritis, okay? That would be a risk. I'd be worried about that in a patient who has a sudden loss of vision in one eye. And remember, visual impairment can be a homonymous heminopic defect with the visual loss in both eyes to one side or the other. And so patients don't always tell you, I lost vision in my right eye. Well, they might have actually had a right homonymous heminopic defect rather than amaurosis fugax. So you have to be aware that patients don't always know the difference between monocular and binocular homonymous heminopic defects. And this is one thing I want our emergency department physicians to test. All you have to do is hold up two fingers, have them cover one eye, and you can test to see whether they have a homonymous visual field defect. It's something our ED docs hopefully do, and our primary care physicians do too. Okay, any other questions? I'll be around here. Okay, one more. The LDL should be below 100. The main thing is the statin drugs are beneficial, but they're only beneficial for ischemic strokes. If you have a patient who had a hemorrhagic stroke, the statin drugs really won't help. The statin drugs only help people with ischemic strokes. If the patient is hypertensive because they've got lots of cholesterol in their body, they probably should be on a statin drug. But again, there's no help from the statin drugs to prevent hemorrhagic type stroke. Okay, one more question. I wouldn't say that I'm an expert at telling that. Obviously, we do know that the HDL is not, is a good sign. The LDL is what we regard as lousy. So LDL is more of a predictor than anything else. So, okay, I'll let you go then. Thanks.